And you can see that the diaphragm on the right side is just filled with disease. All these little studs of white nodules are disease. In the distant past, you were talking about 25 years ago. We really didn't have anything for peritoneal surface disease. When these patients, when this developed, basically that was it. You just went home, and you're lucky if you live 6 months. I mean, it's a very nasty, progressive metastatic disease. But one of the things I think what we are seeing with peritoneal surface is very similar to liver metastasis, and you're seeing the exact same thing happen. What we're seeing is that really, the more disease you remove, the better the patients do. And just like liver resection, if you can get it all, that's the best outcome. And I don't think that, I think we'd be naive to think that when we do total cytoreductions that we really got all the disease. I think in modern times especially, I think that the more modern systemic therapies take advantage of the cytoreduction more than the chemotherapy in the past. So if you leave the medical oncologist with as little disease as possible, I think you give the patient the best outcome. So I really think of this more as, do the best cytoreduction you can. I think there's value to HIPEC. There are people who don't believe that, and I'll explain it a little bit. So what happened in the 90s? In the 90s, there are people who sort of dabbled in it. It was standard of care to do CRS HIPEC for a certain disease process that was very rare. It's called a ruptured mucinous neoplasm of the appendix. You'll see the acronym LAMIN. So that was the standard care for that disease, and it worked well. It still works really well. I mean, you could pretty much cure people if you can get them early enough and get all the disease out. But what happened in the 90s is that people started, and that disease process, by the way, is just very low grade. And it's just, it's the classic jelly belly that you hear about when you hear about this disease process. But what happened in the 90s is people started dabbling with this on colorectal cancer. That was sort of the mid 90s and early 2000s. If you notice there are really famous people in here, like Sugar Baker was probably the best known. Logie, who was in Nebraska, I don't think he practiced anymore. And then Elias is another big one from the US. They started using this in colon cancer. And what they found is that there was better survival. I mean, these patients lived a few years versus not live a few years. So that's what really popularized it in modern times. So what is the pathophysiology? I think the bottom line is the difference between peritoneal carcinomatosis and hematological malignancy is the vast majority of the time, peritoneal surface metastases, when the actual cells, the cancer cells escape the abdominal organ that they originated from. And just imagine them floating around and landing on the surfaces of the organ. So the surfaces include the inside of the abdominal wall, like the floor of the pelvis. Then you have organs that are just kind of freely hanging out there, like the liver and the spleen can have disease, the bladder. And then finally the bowels. So those are the big ones. So you have the organs and the bowels. Anything is fair game with bowels. It could be the surface, meaning the serosa, or it could be the mesentery. And that's really the hardest part to deal with when you're dealing with this disease. Now, even though I say that, there are times, shockingly, that you'll have people with lung cancer and even breast cancer develop peritoneal carcinomatosis. And, you always wonder, like, how did it get there? And I think when you have advanced disease, I think that this disease can travel like through lymphatics and the bloodstream and shed cells through that process. And that's the only thing I can really think of that would explain it. And I think that we believe in very advanced cancers, that's what happens. So the other thing is the way it disseminates, meaning the way it sort of the areas of the abdominal cavity where these sort of seed and then develop are two main areas. One of them is where there's the flow of peritoneal fluid, meaning like the diaphragm and the omentum, and that's why they tend to have a lot of disease. your body makes a little bit of peritoneal fluid every day. And so there is a flow of peritoneal fluid. And those two areas are where you see a lot of involvement because of that. Now, then you have the gutters, a lot of this is gravity. So when you're laying down, you can imagine the gutters are the paracolic areas, by the bowels, in the upper abdomen and in the pelvis. And if you're standing up, a lot of this goes in the pelvis. It's very common to have a lot of pelvic disease because people walk a lot, and that's how really it gets there, is just gravity. Then, of course, the disease has to survive. The vast majority of time when these cells show up in your belly cavity, well, your body fights it; they go away. But some survive, and that's why this happens. The few that survive, it's just sort of a self-propagating process. Once they're there, they form more cells, and the dissemination keeps going. It's complicated only in the sense that peritoneal carcinomatosis, it sort of hijacks your immune system in a way. Like for instance, where you see scar, you see a lot of disease in the belly, or let's say they had previous surgery and there's scar there. Well, it tends to be in the scar area, and that's because your body's immune system to handle the healing is actually like good media for these cells to seed and then grow. And that's what this slide basically says. It just it just sort of hijacks your body's immune system and then just proliferates. And again, most of the time this doesn't happen, but when it does, it's pretty awful. And it's self-sustaining, not only because you can imagine these little tumors then shed more cells, and then they land and they form more cells, and they form jelly if there's jelly, they form fluid if they're forming fluid. So it could be ascites or mucin that accumulates in the belly. But what happens is, imagine the omentum and the diaphragm being like a filter. When you fill that filter, when it gets clogged, okay, what happens then is there's nowhere for this fluid to go. And you can imagine this fluid having all this cancer just laying there, and just, it's open season, because it doesn't even go away, and it just sits there, and it can get pretty awful. I know that every surgeon on this call, I've seen tons of this, and it's just an awful situation to be in. At least for the time being, we feel like surgery itself, meaning just cytoreduction, is not good enough. We think that you actually have to do something like, either whether you give HIPEC or not is not as relevant as just you have to wash out the abdomen. That's either give heat or wash it out. We believe that that's vital to this. So HIPEC, what it does, HIPEC, which stands for hyperthermic intraperitoneal chemotherapy, it actually takes advantage of something called the peritoneal plasma barrier. So there actually is a barrier, meaning, when you give systemic therapy, at least the older systemic therapies, I can think of some modern ones that are better, but the older chemotherapies, they generally can't attack this disease. So if you have peritoneal cavity in your belly, it's just there's some barrier. You can get the liver mets, which are in the meat of the liver, to shrink, but in general, systemic therapy is not. The barrier doesn't allow it to work in the peritoneal cavity. But on the other hand, we can take advantage of that, because we can give very high doses of chemotherapy. We're talking doses that would kill somebody in an instant, very high doses, and we take advantage of that barrier. Very little of it gets in the system. So we can really bombard these cells with huge doses, 10 to 100 times the dose that can be given intraperitoneal. Of course, there are limitations, because the peritoneal, even with heat, the farthest it can penetrate into tumor is no more than 4 millimeters. That's what we believe. So surgery is critical. Cytoreductive surgery is critical, because you either it's better to get it all out, and that's what we always strive to do. But if you're going to leave anything, it better just be like really thin sheets or tiny little miliary tumors that that the heated chemotherapy can attack. You know, there's nothing unique about IP chemotherapy. IP chemotherapy has been given for a long time. It can be given, you know, during the time of surgery when you cytoreduce. It can be given before surgery. You know, you could put in these ports. You know, we call it cold chemotherapy, where you put a port in the peritoneal cavity, and then you can give chemo while somebody is awake. Now, it can't be heated chemo, this cold chemo, but you can give doses or cycles of intraperitoneal chemotherapy. And that's what was done for a long time with ovarian cancer. So, you know, there are other options to give IP, but the reason why we went to HIPEC is because it's a one-time treatment that has been shown to be as effective as multiple treatments when given cold. The great thing about HIPEC too, if you think about it, number one, the patient's under general anesthesia. So patient satisfaction is obviously much better. They used to actually take patients and tip them around, you know, in a bed to get it to slosh. That was the old way of doing it, you know. So you can imagine the patient's asleep. They're not feeling the pain because, you know, chemotherapy, even if it's cold, can be painful. You can imagine it saves a lot of money. It's much more compliant. I mean, when they gave cold chemo, it was rare that someone went through all the treatments because, you know, let's face it, it's not only inconvenient for the patient, it's super inconvenient for the surgeon. And they showed actually with ovarian cancer that very small percentage of patients received IP chemo, cold chemo, that would have benefited greatly from it. There was actually New York Times article on that, and that caused a lot of people were upset about that. And there's all stuff. So the two things I think needs to be remembered. Number one, heat itself is cytotoxic, and I don't think a lot of people know that. In fact, in the old days, they used to use a lot. They used to like use heat to try to kill, you know, tumors on the skin. I mean, you know, people would have to take a shot of whiskey or whatever and bite on something, and they would try to burn it. I mean, we know that heated chemotherapy is cytotoxic for many reasons that are listed on this table. Some of it is cellular, some of it is molecular, but it does arrest malignant cells to a degree. And the other thing is, about it is it actually, when it's given with chemotherapy, it potentiates chemotherapy. It increases the, sorry, it's my dog. Go sit down, boy. It increases the permeability of chemotherapy in the cell. It allows the chemotherapy to get into this, not just permeability, meaning allow the chemotherapy to get in, but actually go deeper inside the cell. The heat helps with that. It also potentiates. There is a potentiating effect, just like chemoradiation therapy. Together, for some reason, it's just better. So that's why the heat and the chemo are both important. HIPEC is being used for a lot of different cancers. Some are very aggressive, and you know, we generally don't recommend using it for things like pancreatic cancer, small bowel cancer, gallbladder. Gastric is still plus minus. And you know, the thing is, who knows, maybe even it can be used for those types of patients, but I think until we're able to really select appropriately, I think that it's dangerous to use them on the more aggressive tumors, because we really don't have data to support it. So it's mostly used for colorectal on this list, colorectal, appendiceal, and nowadays ovarian is a big one that we use it for. Now, we do use it for mesothelioma, but you got to remember mesothelioma is rare. It's, you know, the incidence is 1 in 2 million. So you almost never see it, but it does have an indication for mesothelioma. And then this one in the bottom, this is the one I was talking about, pseudomyxoma peritonei. When I said that that HIPEC was developed for a disease process, it's the one in the bottom. It's the least aggressive out of these diseases. Oops. So for colorectal cancer, the reason I want to talk about colorectal cancer is mainly because this is a general surgery topic, but it's very common. I mean, 15% of patients when they undergo surgery have peritoneal carcinomatosis at the time of surgery. It's the second most common area that that the disease metastasizes to, besides liver, which is number one. This is the important point, in 25% of all patients with recurrent disease, the peritoneal membrane is the only site. So, there are 150,000 cases of colorectal cancer in the United States. So you can imagine 1/4 of those patients, it's a huge number. So we're not capturing all the patients that can at least potentially benefit from at least cytoreduction. I mean, who knows about HIPEC, but there is no doubt that cytoreduction at minimum has huge benefits, and that's been shown over and over again. So what happened with colorectal cancer is, like I said, in the 90s and the early 2000s, people dabbled in it, and then they were seeing better and better results. You see now we're getting into the 2000 up to 2005. There was a randomized prospective study, a Dutch study, that showed an advantage, a survival advantage when the control arm, though, however, was systemic therapy alone. So it was CRS HIPEC versus just IV chemo. And that trial, which I'm sort of summarizing here, had 105 patients, and it was very common to how we do HIPEC today. We usually give 6 months of systemic therapy total, meaning 12 cycles. Usually we give 6 cycles before the CRS HIPEC, then the final 6 cycles afterward. Now we do that, we have nothing to prove, whether giving it all up front or even all adjuvant may give you the same results. But in this one study, which has a lot of faults, and I'll explain why, it was published in 2004, you can see the median survival was 21.6 months. That's huge compared to what it was back then if you did nothing, if all you gave was systemic therapy. And one thing I want you to notice here, though, you can see here, even the median survival is almost doubled when you give a systemic versus HIPEC. One of the things that's notable, though, is the mortality rate. And the mortality rate back then for HIPEC, and this is why it got a bad reputation, is because it was considered such a horrible treatment. There was a huge amount of morbidity, and 8% mortality. That's huge. I mean, even back then, even major big abdominal operations had no more than a 3 to 5% mortality. I'll tell you, in modern times, it's well below 2%. Like, I think ours is less than 1%. So really, it's just about, it's the experience of the surgeon, it's the experience of the institution. There's a whole process to these HIPEC patients. I know Jennifer knows a little bit about it because she's rotate with us. But nowadays, it's even more automated than when you were there, Jennifer. I mean, it's really, we have a whole team of people that know how to deal with these patients and have them recover safely. There was actually a follow-up to that study in 2004, and they continued to find a benefit. And you can see here the 5-year survival, and that's incredible, in the HIPEC group was 45%. That's the same thing we were seeing with liver resection. And that's why I mentioned that it's just mirroring what we saw with liver resection. The major criticism of this trial, though, and I think it's obvious, is it didn't use modern chemotherapy. I mean, they just used 5-FU and leucovorin. They didn't even use oxaliplatin. So that's a huge criticism, because modern chemotherapy definitely works much better than the old stuff. So you can see, what was happening is then people just kept using it, and you had a ton of retrospective studies that came out in in 2010 plus, that showed a benefit. I mean, you can see these overall survivals are really good compared to what they were in the past. So that's why HIPEC, I think, became popular, because we were seeing obvious benefits. Now, how do we select patients? I think number one, we have to be safe, and safety is always first. And I think there are a lot of factors that play a role in safety. Some of it is surgeon related, some of it is institution related, Some of it is patient related. You have to be careful about who you choose. The goal is always to remove all the disease. That's the primary objective for this. But like I said before, this does penetrate, a little bit into these cells. So we accept something called a CC1 score. CC stands for completeness of cytoreduction, and that means tumors no larger than 2.5 millimeters, not centimeters, millimeters can be left in the belly, and we think that there's a benefit. At least we've shown there's a benefit. And this is an example of what I mean by that. When you do an RO or /R1, so an R1, R0, R1 is equivalent to a CC0 because basically anything you left behind is going to be microscopic. You can see how the survival went way up compared to when you did R2 resections, meaning when you did HIPEC and left stuff behind. I mean, it's not even comparable. And that's why the cytoreduction is the critical part of it. And in these studies, they use modern chemo. This was an old stuff. This is the more modern stuff in these studies. Patient selection, it depends. It all depends on the skill of the surgeon, the experience of the surgeon. We used to have really rigid criteria. Now I don't think that's the case. I don't know if you guys remember liver resection, but there was a time that we had really rigid criteria before we did liver resections. You couldn't have more than 4 metastases. They couldn't be on both sides of the liver, and what you're seeing now because of experience is as long as you can get it all out, if you have the skill to get all the tumor out or leave tiny disease behind, then you should go for it. That's sort of the attitude about HIPEC. Obviously perform status. When I talked about safety, I meant it. I mean, I don't operate on anyone that's an ECOG anything greater than 2, and even 2 is pushing it. But a 3, 4, 5, I know they're not going to do well. And it is tough on the body. It's mainly because of what it does to the gut. It takes a while for the gut to wake up. That's the main issue. This is how when I do HIPEC, I give the patient a PCI score. PCI just means peritoneal cancer index, which stands for how diffuse and how large the disease is. This number can be 0 to 39 because you can get a score of 3 in 13 different regions. 0 is, I guess, is a region. So that's 13 regions. Again, our goal is to get it as flat as possible, as thin as possible. And the actual, the cytoreduction part of it is the tough part. People talk about HIPEC. The reality is the skill of the surgeon or the experience of the surgeon in the institution isn't about the HIPEC. I mean, the HIPEC is automatic. I mean, it's after you've done a ton, it's really easy to set up. Anybody could set this up. But really the skill is being able to get the disease out. It usually requires peritonectomies everywhere, or multi-visceral resections. Some of these areas are very tough to get to, in the very crevices of the body that are hard to get to. And it just requires experience, really. I mean, obviously it requires some skill, but the reality is it requires patience and time to get good at it. It is a big incision, from chest to pubic bone. This is kind of an example for the non-surgeons. I know that the surgeons know this, but what's done, this is an example of a peritonectomy. So you imagine, see this is muscle. This is a diaphragm muscle where I'm putting my arrow. And these tumors were sitting on the diaphragm muscle, but what they were really doing is they were sitting on the peritoneal membrane on the diaphragm muscle. So you can actually strip the peritoneal membrane, and in doing so, you could remove all this disease. So this is an example. You can't always do it, but many times you can. So you can have 1,000 tumors in this sheet of peritoneal membrane, but you can get them out by just stripping that one area. This is just one area. You have peritoneal membrane in many spots in the abdominal cavity. This is just an example. When you do a right upper quadrant peritonectomy, you can, you basically strip it to the muscle, the diaphragm muscle. And then the HIPEC, like I said, the HIPEC is really just what you do is you put inflow and outflow tubes with temperature probes. Then what you do is you close the belly. You close the abdominal cavity with a running suture. And then you use a reservoir, which has a roller pump and heat exchanger. And so you do a continuous perfusion for, whatever you do. Like it could be 30 minutes in some cases, and it could be 90 minutes. 90 minutes is kind of like a standard that we use for most of the time. And this is how it looks. This is actually the OR. This is exactly how it looks. You have the perfusionist here, and they have very fancy systems that cost a lot of money, but we make it really simple. You can see that this is the reservoir. This is the unit that's the roller pump and the heat exchanger. And then what you have is you have inflow and outflow tubes. So I don't know if you can see this tube up top here, but you have two tubes. And, inside the belly, the tubes are forked. They're extensions so that they can get around the belly. And then these small wires are actually temperature probes. But this is how it looks like during the cytoreduction. And then, of course, you have the student, massage the belly so that they get the chemo all over, or the resin, I guess. You can see this is an example of how popular HIPEC became. This is the Netherlands. And you can see, how the percentage of patients who had the disease, only 4% that were seen in the early, 2005. And as you got near the end of that decade, it doubled. It just became more popular. KU's volume, same thing. We're sort of plateaued at about 50, 55 a year. Sometimes we go up close to 60 a year. Those aren't patients we evaluate. Those are the patients who actually undergo HIPEC. About 20% of the patients I can't do. It's like a peek and treat. I go in and I can't do it. So our numbers are around 20%. When I started this, it was like 50%. When I started doing HIPEC, and I'm not afraid to admit it. I mean, there's at least half the time I couldn't get it done. It's all about, experience. And you can see with time, these are just various studies. You can see that mortality started going down, and that was very favorable for us. And morbidity was around 25, 30%. And that's what you'd expect from any major abdominal surgery. Now there is a learning curve. I don't know how accurate this is, but I don't think these are not numbers set in stone, but it's said that you have to do about 140 cases. In some studies, it says even more, and some it says a little less, before you're most effective and most safe. And that's a big number. And I think in modern times, because we have so many, not a lot, but we have enough senior HIPEC surgeons, that I think when you're a center that's beginning to do this, I really do think it's unethical nowadays to do it without someone, mentoring these early surgeons. In the past, you didn't have a choice. It's just like liver resection. There were no people who could teach it. But now I think we have enough people where I really always encourage smaller centers to have somebody go out there and watch them do a few. I mean, I learned watching Dr. Sugarbaker do a few. I mean, I learned a tremendous amount just watching Dr. Sugarbaker do a few. It changed everything, my whole capability of doing it. So, there's a little bit more to this, but in conclusion, obviously, patient selection is key. You got to be safe. There are controversies, and the controversy came from this trial. This is something called the Prodigy trial. I'm sure people have heard about it. This is a French trial where they randomized patients to CRS, meaning cytoreductive surgery, versus cytoreductive surgery and HIPEC. Now, note that in both cases, there's cytoreductive surgery. It's unethical not to do cytoreductive surgery because patients live so much longer. So really, what they were trying to study is the inherent value of HIPEC, whether the HIPEC mattered. And what they found, so this is the schema, which is very basic. They all receive systemic therapy, which is given. But what they found is, and this is sort of like more about the design, but you'll notice there are a lot of things that I'll point out. The most important thing is that the HIPEC regimen they used was oxaliplatin. They used oxaliplatin, and they only did a perfusion for 30 minutes. That is completely counter to what real HIPEC surgeons will do, because I think France was just beginning to do HIPEC when they came up with, they assumed oxaliplatin was a good IP drug, but it's not a good IP drug. It doesn't work IP. And I'll show you an example of that. And these are the more numbers. You can see that it was equivalent. So survival was the same, whether or not you gave the HIPEC. So that's what led to a lot of the controversy with this. But again, I think the key points to this, the problem with this design, and it's really obvious, is they used the wrong agent and they didn't do it for long enough. So, we're convinced that if you would have done it, for 90 minutes and used mitomycin, you would have seen a difference, because we know mitomycin works IP. And this is actually, this is a study I did when I got to KU when I wanted to get into HIPEC. This is a human colorectal model in mice. Okay, and you can see this is the various, these are the various treatments. So we found that when you gave combination therapy, it was better than mitomycin or oxaliplatin. But notice oxaliplatin, it's the purple. Okay, look at this. They immediately died as soon as you gave. They were no different than giving just water, and they're like just water in the belly. Now notice mitomycin C. Look how far out it goes. They go very far. Now it turns out that when we added irinotecan, or we even added panitumumab, we actually had to euthanize the patients because they live, the mice, because they live so long. So, there is basic science data, and, Sugar Baker has a ton of it. Oxaliplatin cannot be used IP. It doesn't work. It's not the same mechanism. And I think people have to understand that what works IP is not what works IV. It's totally different. They have different ways of getting into the system or into the tumors. So in other words, I think the key is, there is an American study that's being written. This is, that is being proposed. Hopefully it'll one day. I'm really upset at all the cooperative groups. I no longer go to their meetings because, they're just so unfair to surgeons, I'll give you an example. Like, when that study came out, okay, remember that study I just said, the French study? This was actually what was on their bulletin. Hyperthermic intravenous plus cytotoxicity does not improve survival. Look at that statement. It's huge, right? What this should have said is oxali-based hyperthermic. Could you imagine if we wrote off chemotherapy in the past when it didn't work for over a decade? It just came down to what agent you use before it works. And it really upsets me. When you look at something like glioblastoma, glioblastoma is a terrible disease. And, so they tried, bevacizumab when they treated it, and they found that bevacizumab does not work. Okay. So when you looked at the study, when they actually had a bulletin on this, they said bevacizumab does not improve survival in glioma. They didn't say that molecular targeted therapy doesn't work on, gliomyosarcoma. See how unfair they are to the surgeons, and they won't even let us do our studies. It's just like an act of God because we have such problems with the medical oncologists. And I hope there are some on this call, because it is an actual fact that we're not treated fairly at these meetings at all. So what's interesting though, this is really cool, because see, as much as, first of all, I love GYN oncologists, but I think, we're much more anal about dealing with the abdominal cavity in a lot of ways. But the GYN oncologists did it right. You know what they did? They put everybody in a trial from day one, because they have their own organization. They do their own studies. They get their own money. So they don't have to worry about the medical oncologists. So what they did is they actually put all these patients, and what they found is there have been 2 trials now, 2 randomized prospective studies that showed if you just cytoreduce, you didn't do as well with cytoreduction and HIPEC. Okay, and the HIPEC they use, which is what we use here, has been proven to be beneficial in ovarian carcinomatosis. It's not oxaliplatin, it's cisplatin that works for ovarian. So it's very specific. And they give heated chemotherapy for 90 minutes, not 30 minutes. You can see when the study is designed right, they showed huge benefits. I mean, it was really pretty remarkable what they showed in terms of value. Even the 3-year disease-free survival was more than doubled when you gave the HIPEC versus no HIPEC. So you lived about a year longer if you got the HIPEC versus no HIPEC. So these are equivalent patients, very equivalent patients. One got HIPEC, one didn't. And you can see this is what upsets me about cooperative groups, is that they don't give the surgeons a chance to do their real trial in the United States. And that was only based on one trial. So I'm going to finish this. Obviously, despite all that I say, we dug our own graves. We made our own beds because, as general surgeons, when we started doing this, these surgeons that were high volume surgeons should have put everybody on trials, like Sugar Baker and all those original surgeons right from the beginning, but they didn't play nicely. They wanted to make a lot of money. They were in their little, community hospitals. And they were secretive about HIPEC. You see, that was the world of HIPEC when we started to use it in colorectal. So we kind of dug our own grave on this. We could have had so much more information. Right now we're still working on patient selection, what agent works best, some of the basics, how to give it, the temperature. So that's one thing. I think some of the controversies are, should you give HIPEC in patients with T4 tumors? Because this is when you do the first resection. If it's a T4 tumor, should you give HIPEC? That's something that's being studied. Do you do it when patients have liver or lung metastasis? I'll tell you at KU we do. We probably have 50 or so patients we did it, but we only do it when there's limited volume. We have a patient who underwent liver resection, lung resection, and HIPEC. She's disease-free 7 years later. And this is for colorectal cancer, you see. So I think if you choose the patient correctly, you can go ahead and even do it with other metastases. So, at KU, I do have a trial, we're almost closed. This is not a trial that compares HIPEC versus no HIPEC. I'm just trying to discover what's a better agent. We've had studies that have shown that melphalan may be better than mitomycin. That study has accrued really well. We've actually accrued, we've screened 102 patients. Actually, it's more now. This is 6 months old, this slide itself. And at that time, we had 84 patients that were randomized, and the goal was to randomize 100. So we're almost there. And this is done through the Cancer Center. I wrote for a grant through the Cancer Center, and it was approved in 2017. So we're almost there, but this is to do more and more trials. I honestly think it's going to be hard to accrue to a no HIPEC these days, because patients come into clinic wanting HIPEC, you see. So if all of a sudden you tell them you've been randomized to a non-HIPEC arm, they don't want to be in the trial. We've tried this, and it doesn't take off. These trials don't take off. So I think, at this point, I think we should do what we did with liver resection. I don't know if you know this, there's never been a randomized trial showing liver resection for colorectal cancer has value. We just started doing it, and people were living longer, so we kept doing it. So I think the future, honestly, is just trying to find better and better agents, trying to go backwards and determine whether to or not to give HIPEC. I think in the United States, we're a country that, we want everything done. God bless it. We want everything, and so our culture isn't like the Europeans. They're much more liberal. We want to go full bore in the US. So I think it'll be very hard to do a trial where one arm is no HIPEC. With that, I'll end the talk. Thank you.
Well, that was fantastic, Dr. Alkaspoulos. Thank you very much. Mary Beth has put the sign-in code. I'm sure there's lots of questions in the audience, and you can either type those in the chat room, or if you would like to unmute yourself and ask. I have, maybe to start off the questions, what do you do with peritoneal surface disease recurrence? So they've undergone HIPEC, and now you're following them with serial scans, and you start to see maybe some momental studying. Yeah, you mean they've already had, yeah. So the answer to that is it depends, and that's a great question.
You generally don't want to do this operation more than once every couple of years. So let's say they have an early recurrence, like a year later, they have a recurrence and it's not high volume. I don't jump to the OR. We give the patients more systemic therapy. We let the disease declare itself. And maybe at the 2-year mark, I'll go in, and do another HIPEC. There has been value shown in doing repeat HIPECs. The most I've ever done on a single patient is 4. But I'll tell you that 4th one, that patient did not do well. They didn't die, but they let for like 2 years, they had this awful fistula. They just lived an awful life for a couple of years. And I regretted doing that 4th HIPEC. I mean, you can imagine the adhesions are tremendous, So to answer your question, I think it can be done only if you can get all the disease out, just like the initial HIPEC. You have to have the same rules as you did with the initial one. Kind of like liver resection, going back and doing more liver resection. Very similar.
And as far as if you had to go back in someone's belly for maybe a non-oncologic reason, is there a time frame where it's almost impossible to get back in? Is there a time frame where it's safer?
No, I honestly think it's the peritonitis that happens from HIPEC is tremendous. I would hate to go in any sooner than about 2-3 months, in a belly after a HIPEC. I've had to do it a couple of times. It's nasty. It really is nasty.
Well, just a question for you from the community. A lot of times we'll see these patients back, maybe with an ileus or a problem. So is it best in someone who's, let's say, within the first 3 months? Because we'll see this sometimes in the community programs, and you guys are pretty good about taking your patients back, but sometimes there just aren't the beds. And should we just put them on TPN and manage them conservatively? Is that?
Yeah, that's a good question. I think that depends on the situation. I think when you get down to the point where you're giving TPN only for the patient to survive, I think I can say safely, usually in those cases, a repeat HIPEC won't work. In other words, the patient recurred quickly. It's really bad disease. It's declared itself. You can give systemic therapy if you can get them to that, and if they don't respond to systemic therapy, I would not take them back. That's way too soon. That's a good question.
I would guess too, I would consider that first 3 months, like you were talking, that truly a hostile abdomen. And I was thinking in cases where you guys can't get them into their beds and they have a bowel obstruction, let's say in that first 3 months after a HIPEC. I mean, do you think it's reasonable to wait 3 months and just kind of tough it out and see what happens with them?
Yeah, I see what you're saying. So you're saying not necessarily a lot of disease, just sort of like an area that, I don't know. I hate when I hear stuff like that because I take it, honestly, I think it's terrible that, that when patients undergo HIPEC, they can't come back to KU because it's like you said, it's always better to go to the original surgeon, especially if they've done a lot of, work in there, just like if you had a patient,
Sure.
and you had operated on a patient. So I do believe that we should get them to a HIPEC institution as soon as possible. So I apologize when that happens. And please call me if you encounter that.
Well, and as I said, you guys have been very good about taking our patients we send or other folks that you've operated on back in those circumstances. It wasn't a criticism, but I just know with COVID and the bed limitations we've had.
I know it was a bad time. Yeah, it was a horrible time.
We in the community have to do the best we can with the cards we're dealt. And I tend to think maybe these are better handled conservatively for a period of time, probably, avoiding operations in that first 3 months. So
agreed, 100% agreed.
Do you ever have conversations about, or have you ever thought about, is there something about the biology of these cancers which makes HIPEC most appealing? I mean, like thinking about it from a breast standpoint, in theory, right? I could do a mastectomy and an axillary dissection, put some heated chemotherapy in there and shake for an inflammatory cancer, let's say. Like, is there something unique about the abdomen or about the tumor biology that makes this especially pertinent? So I question for lung, right, for example, or sarcoma or something like that.
Yeah, and I think that's why I think I put that slide up. I think some of the controversies is patient selection. What I meant by that, as I think I implied, is that about the biology. We know that it doesn't work for some patients. This, like Dr. Hamilton said, and his case is a little different that he was describing, but there are patients that recur within 3 to 6 months, and you really haven't done them any good. Not only do they recur, I mean, they recur with a vengeance, and so we're just, we're starting to do molecular correlates. Again, we're behind. We're very behind in the HIPEC world. So we're starting to collect molecular correlates now, not just molecular profile of the tumor. We're looking at, circulating DNA, tumor DNA. In fact, there's a medical oncologist that's sort of using my patient population and looking at that. Should we not do it in patients who have circulating DNA? Probably not. And yeah, I think that one day we'll know, we'll have a much better idea when we know more about the molecular correlates and who benefits from it. So I think that's a great point. And that's why it upsets me even more that we lost all of those patients, tens of thousands of patients. We could have had them on trials looking at correlates. It's terrible. We dug our own grave on this.
Yeah, I think, Kelsey, it's a really interesting question. It has to be something about tumor biology. And I think it's also a lot of these histologies are, colorectal cancer, when it spreads to the liver, is pretty chemo responsive. And I compare it to retroperitoneal sarcoma, where people have tried, we know, like I said last time, even if I take out all the tumor, I do not take out all the tumor, right? Retroperitoneal sarcoma is a recurrent disease. And it's a locally recurrent disease. And so you would think, take the plan that's been developed by the peritoneal surface malignancy folks, get good surgery, wash the abdomen with what ends up being liters and liters of water, perfusing it for 90 minutes with heated chemo. And it should work with retroperitoneal sarcoma, and it does not.
No, it does not. Yes, you're right. It does not work at all. And, I did a few. Those patients never did well. I mean, they recurred quickly. So we stopped doing it for sarcoma. We did a few early on. And, as a country, as a nation, we were doing it too. And, a lot of studies came out on Annals of Surgical Oncology saying it doesn't work. So, it's been stated now not to do it on sarcoma. So you're absolutely right. Some argue signet cell neoplasms of the appendix, they don't do well, and we probably shouldn't be doing it on signet cell. That's another thing that's come up recently. Yeah.
I
think, sorry, Dr. Hamilton, go ahead.
Just a follow-up question too. Have you guys done any studies where you've measured blood levels of the chemotherapeutic agents that you're giving during the chemotherapy? And, how much of this may be a systemic effect, and maybe a systemic effect that can't be attained in any other way as you're doing this? And if you've noticed there are differences between the agents that you've been using in terms of their systemic absorption.
Yeah, that's a great question. So, who knows that is there were a lot of articles on the pharmacokinetics of HIPEC. Dr. Sugarbaker wrote 100+ articles on this. So he used to look into that. He looked at, plasma levels, tumor levels. I mean, if you go to his OR, at least it was 20 years ago, you had PhDs running in and out of that room, collecting tumor and looking at pharmacokinetics. And I know it may seem like what we're doing is sort of like, just whatever, but there are pharmacokinetic studies that are done. But you ask a good question, is it that the HIPEC that escapes in the peritoneal fluid, the blood, responsible? And maybe, the answer is maybe, until we prove that there's like ovarian cancer, we need to prove there's an inherent value to HIPEC. And, I am happy that ovarian cancer proved that, despite it not being my disease. I scrub into those cases, but at least we know that's a possibility that HIPEC can have inherent value in HIPEC. Yeah.
Dr. Hamilton, there is some animal work showing that tumors, or animals with peritoneal tumors that are heated live longer than animals with peritoneal tumors that are just washed. And this makes sense, right? Like, nothing in the body likes being at 40 something degrees for 90 minutes.
Yeah.
but it's, the local versus systemic effects with HIPEC, the little bit that I understand, Dr. Alcaspouls does this every day. I did this in fellowship and thankfully don't have to do it because Dr. Alcaspouls does.
Yeah. So
But-
for instance, melphalan is like, so it's 80. So what we basically shoot for is that 80% of the drug is absorbed by tumors. So Dr. Sugarbaker has done these studies. For mitomycin, it takes 90 minutes to do. For melphalan, it takes 60 minutes. So there is some data on this stuff that's out there that, in the beginnings of all this. I think today the important questions are what were brought up. It's all about patient selection. What patients will be. Obviously, not everybody, not even close. But how do we choose the right patients? I think that's critical.
Yeah, is anybody doing, genetic marker research into the folks that respond well? For example, that, ovarian cancer makes perfect sense. You have a disease that spreads intraperitoneal,
Yes.
either by seeding or by the peritoneal fluid circulation. And that's very clear just to how the deposits are and also how well it responds to the debulking. And I do think in colorectal cancer, there are similar types of colorectal cancer that
Yes.
behave in this way. And they're probably the ones that we get the good responses for. And it'd be really cool if we could figure out, what those
Yes.
tumors are and then select the therapy for it.
Yeah, there's stuff that's starting to show up in the literature. These young surgeons, I hate to say it, but I feel like an old timer now with HIPEC, but these young
You're a
surgeons
young
are
guy.
really energetic. They're really energetic. They're doing all this stuff that you're talking about that we neglected to do, unfortunately. Yeah, they're doing this stuff. Nowadays, there's gas HIPEC, aerosolized HIPEC, and they find that actually goes into cells further in. It permeates more than the liquid. So they call it PIPEC, I think, PIPEC.
Yeah.
And so people are looking at that now. You just
Now,
basically,
are they passing gas through the abdominal cavity? Because
yeah.
if
They
you want to
shoot
be
the
in
air.
an OR with aerosolized chemotherapy.
That's exactly what it is. It's aerosolized chemotherapy. That's exactly.
Yeah, Dr. Hamilton, it's essentially, it's not the same setup, but it's analogous to a laparoscopic insufflation setup with a
Yes.
whole lot more, paying a lot more attention to how that gas leaves the abdomen than you do when you're doing a lap case and the CO2 just leaks the whole time. But
Yeah.
it's the same, it's analogous to that.
Cool.
I got to tell you something. The only systemic agent that I've seen that has done wonders in peritoneal surface disease, and it's hit or miss, is immunotherapy, Keytruda. I've seen Keytruda in 2 or 3 patients make that disease almost melt away entirely. It's shocking because nothing else works like that. But so I think if you have, like you said, you were mentioning molecular profiling. If you have the right molecular profile, right, we know that at least IV Keytruda works, and we need to do the same with IP stuff. What is the right signature, where it works? Yeah, it's really interesting. I'm amazed by immunotherapy. It's hit or miss, but boy, when it hits, it hits. It's really remarkable.
I think we've all seen that. And
Yeah, it's just unbelievable.
I go to lung cancer conference, and when I was a resident, these people would die within 6 months to 2 years after they were diagnosed. And now we have people
Yes,
with
yes.
responses who are living 5
Yes.
years, and it's incredible what these new drugs do. Melanoma is becoming in many cases curable, and it's something we never
Oh
could think
God,
of it,
no. Yeah, they actually ask us nowadays, they ask us to operate on advanced melanoma. That was unheard of. If you had Mets, you were done,
Right.
But nowadays we'll go in and cytoreduce the stuff for the medical oncologists with their immunotherapy. It's really interesting.
Yeah. I had one patient with melanoma. I think I did 3 or 4 separate major resections on him, isolated recurrences, and he lived about 9 years, and he finally died of something I couldn't re-resect. But
Mm,
it makes me wonder if he would, if we've had these drugs.
Yes.
Here,
yeah.
All right. Well, this has been fantastic, Dr.
Well, it's a pleasure. Thank you so much for doing this. I really got a lot out of it. Thank you. Appreciate it.
Fantastic talk, highly interesting. Just to draw everyone's attention, if you bring up the chat box, Mary Beth Warren put in ways that you can